Hello, welcome to the Geri Academy podcast with your host, Geriatrician Dr. Sharafsaleh, providing you with information on aging-related topics. Learn more at geriacademy.com and follow me on social media. Hello, welcome to the Geri Academy podcast with your host, Dr. Sharafsaleh, and today is episode 10. Today, one of my colleagues, Dr. Allison Combs, is going to talk about the 5 geriatric M's and pretty much talk about when someone needs to see a geriatrician and what a geriatrician does. I also have the peanut gallery here, as usual, my 2 geriatric fellows, Dr. Wang and Dr. Cannon. Dr. Cannon's a little sick, so we're going to make her sing. Dr. Cannon, hit it.
Geri Academy.
Thank you. So, welcome, Dr. Combs.
Hi, it's so nice to be with you.
Dr. Wang just said we should cut that out.
Should probably cut it out.
No, it's great. I think it's great.
I blame my toddler for my cold.
All right. So, Dr. Combs, you wrote an awesome blog on the Geri Academy website called the 5 Geriatric M's. Where did this come from?
So this is a concept that Dr. Frank Molnar first developed, and it was just kind of a way to explain what geriatricians can help. So he came up with kind of this easy mnemonic, so 5M's.
On our website, and you created this wheel for our patients to see better, and I thought it was such a good idea that we went ahead and put it on the site. So for those who haven't seen the blog, I really recommend that you see it. Can you start maybe with one of the M's? Tell us what it's about.
Sure. So we can start off with mind. That's probably the easiest to delve into. So when we think about the mind in an older adult, we think about mentation. Is there any problem with mentation, dementia, delirium? Things like another thing that we think about is mood. So are they suffering from depression or anxiety? Are their medications not working for those anymore?
Okay, great. And one of the other M's is medications. That is one of the biggest things that we talk about in geriatric medicine. We tend to simplify medication regimens for our patients. We tend to what we call deprescribe. And a lot of times as patients get older, the medications that they used to use may not be appropriate. So you should check out the blog on Am I Taking Too Much Medicine? But Dr. Combs, tell me a little bit about that M.
Yeah, so for medications, I always tell my patients we are the rebel doc, and opposite from most you will meet in that we like to take away medicines instead of prescribe medicine. So we really look at, are you on the right stuff for your age? Do you still need this anymore? Is there a benefit? Are you having side effects now that you weren't having when you were young? Are you taking just too many pills in general? Do we need to cut down or simplify the number of pills you're taking?
Okay, great. And so the next M is mobility. Trying to tell you guys again, there's another blog on our falls taking you down, falls, movement, being independent, super important to geriatricians. Tell us a little bit about the mobility M.
Like you said, we think about falls. We also think about preventing falls. So are you having gait or balance issues that we could help with before you have a fall? Are you using the right type of assistive device? Do we need physical therapy? Basically anything we can do to help keep you independent and going is the focus of mobility.
Okay, right. And I think maintaining independence through mobility really prevents from developing frailty. We did write a blog on frailty. Dr. Cannon wrote the blog on frailty, and there's this like frailty spectrum that she drew out. I think it was beautiful, but talking about how as time goes by, we can kind of go down this spectrum of frailty before we have no function. And pretty much we could die because of frailty. And so the first approach to preventing frailty would be to stay mobile, to stay independent. Okay.
That remind me, the patient that I saw just a couple of days ago. She is 85, but she looked like she was 65, and I feel like besides genetic factors, the fact that she was so active, she was in all kinds of sports team when she was younger, or even into her 50s, and even like a couple of years ago, she was still skiing.
Yeah.
Absolutely.
Absolutely. Right. And I remember you told me, you said she's in her 80s, but she looks like she's in her 60s because she's so fit. And it is because she was so active all of that time.
Mhm.
Exactly. And talking about the next stem, which is multi-complexity.
Yeah, so that's a great lead in thinking about frailty. That's really the kind of complex interplay between all the different disease processes that you have going on. And those really overlap. So we can help with kind of a clinical frailty scoring. Are there things we can do for those diseases to help you stay independent? We can also help with talking about your disease that you've had since you were younger, but it getting worse as it advances, and what we can do and change treatment. Another thing we can talk about are you going in and out of the hospital a lot? Is it time to rethink our goals? Are there complex things outside of your health that are making this complicated? Your living situation, your financial situation, and how that affects your overall health and well-being.
That's really important. And sometimes as geriatricians, we take this holistic approach to care. And that is really what these 5M's talk about, right? The mind, medications, mobility, multi-complexity. And then the next stem that we'll talk about now is what matters most to the patient, right? So talk a little bit about that.
Yeah, so with that, we just come in and ask, what matters most to you? And we focus on that and make sure that what we are doing as doctors, that the treatment matches your goal. So if your goal is to spend time with family, interact with your children and grandchildren, we want to do everything we can to make that happen. We have a lot of patients who don't want to be on machines, who don't want to go through whether it's dialysis or be on a breathing machine or any of those things. So we help them write those wishes down and put it in the medical chart so that their treatment plans align with those goals.
Right. I think that a lot of times in the hospital setting, we do medicine. We just do medicine. We do what we're good at. We have algorithms and we do the things that need to happen next, and heart failure and COPD with whatever disease process the patient comes into the hospital with. So if a person is in their 40s and 50s and 60s, that might be completely appropriate for them. But what about a patient that may be a little bit older and they may actually need a more invasive therapy? And that invasive therapy could cut their life short, could cut the quality of their life, could actually interfere with them spending more time with their family. And that is why what matters most to the patient should be almost at the center of the discussion, so that when we know what matters most to you, what your goals are, then based on that, we can sort of structure healthcare around that. But also knowing what matters most to you, right? Then we can talk about, hey, let's focus on your mind. Let's focus on the medications. Let's focus on the mobility. Let's focus on the complexity of the situation, and you as a person are like at the center of it all, right? So I kind of want to go back a little bit and talk about the mind and just briefly go over some of the diseases that are really common for us as geriatricians. So let's talk about the mind and some of the diseases that geriatricians are used to treating and that we're particularly good at treating older adults for.
Definitely. So I think a huge part of what we do is look at memory loss. So memory concerns, whether that is forgetfulness with aging or mild cognitive impairment, or more advanced being dementia, where you have trouble in multiple areas of how you process information. Another area that we do a lot with would be depression. And I think that is something that really affects older adults, but they're sometimes, don't talk to their primary care physicians about it because there's such a stigma with depression and anxiety.
So there's a stigma with depression and anxiety, especially in older adults, where they think of it as a sign of weakness, especially that generation, right?
Yes.
The individuals that are in their 80s and 90s, the diagnosis of depression was sort of taboo for them. They didn't really see it as a real disease process. Although we know that depression has to do with chemical imbalances in your body, and not just that, but also the experiences that a person has. One of the newest blogs that we just posted was some myths on aging, and Dr. Wang talked about that. It was talking about how, you have loss of a loved one, you will have chemical changes, you have disease processes, you have isolation, especially now with COVID, and all of those things can lead to depression. And not to consider the depression is not a true diagnosis, because it is, and there's help. We can always treat it. So that is why the mind is so important.
I think with my patients, I try to destigmatize it and just say it is absolutely like having high blood pressure. You have a disease that we may need a medication to help with, and there's nothing wrong with that.
And also, just because you've been diagnosed with depression doesn't mean you need to be on lifelong medicine. Sometimes we take the medicine for 6 months. If that acute stressor like isolation or a death of a family member or moving that could kind of spearhead the depression, if that's gone, the depression might have resolved with treatment for 6 months, and then we can see how you do off medication. It's not a lifelong medication for some. For some it is, because that's just how they were made. There's nothing wrong with you if you do have depression. It's just that's how you were made. Just like I'm on a sleep medicine rotation right now, and sleep apnea, it's just how you're made. It's just how your throat is. It's not anything you did wrong. It's just your genetics.
And what about this new data that's really come out that we talk about, like briefly? Let's talk about sleep apnea. And we probably need to do a whole blog on sleep apnea and a podcast on sleep apnea, but that, untreated sleep apnea can increase your risk of dementia. Right. And so,
And other things.
And treating it would help with dementia too.
Exactly. So one of the things we were just talking about was medications. How about medications that actually do cause depressed mood and we take patients off of, like Benadryl, urinary incontinence medications, overactive bladder medications. There's a bunch of other ones too, but that actually cause you to get depressed that you may not need.
I was going to say these are all the 5M's where it's all connected, because once you treat the depression, once you're getting better, you seek other non-pharmacological ways, like psychology counseling sessions, and you get rid of the medicine, so you simplify your own medication regimen, which also will make you happier than if you're taking tons of medicine.
And exercise is always good for depression, which helps decrease your risk of being frail, which helps to decrease your risk of having a fall, which also helps you combat osteoporosis, because weight-bearing exercise can help combat osteoporosis
and make you less frail.
Yeah, exactly.
Everything is connected.
Tensegrity. That's the thing that we, as DOs, we talk about tensegrity all the time, how everything is all interconnected within one.
So this circle of 5M's has so many levels and meanings.
Did you just sing the circle of life?
Please say.
She's like whispering under her.
I love it.
The circle of geriatrics. That's right. All right. Well, Dr. Krebs, I really enjoyed reading your blog. I love the way that you summarized Dr. Molnar's 5M's. I love that he created this, because it just makes sense. And it just, I think, helps me as a geriatrician talk to my patients about how to care for them and sort of our approach to caring for patients. Like, I love it. I absolutely love it. Anything else? Any recommendations that you have?
I would say see a geriatrician.
Always.
We're
awesome. Yes.
There's usually something we can help with at any point in your older years. And I would say, just establish that relationship with them. They are there to help you go through the many changes as you age.
Right.
And they have great advice.
Now, are you saying see a geriatrician as a primary care doctor or in the hospital or as a consultant outside of the hospital in a memory clinic? Like in what setting should people see a geriatrician in?
Any,
right?
Yeah.
All of the above.
Any settings. So we typically do work more as a consultant. So just like you see a cardiologist for your heart or a pulmonologist for your lungs, we work as specialists who see people 65 and up. But there are geriatricians who do primary care. There are geriatricians who see people in a clinic, in a memory clinic, in the hospital. So we work in a variety of settings and can help you where you need help.
Yeah, and in the hospital setting, I've noticed that I think we're super blessed that we do get to see patients in consultation in a hospital setting. Not every hospital system has geriatricians doing consultation, but when patients have delirium, which we did write a blog about and we did talk about, when patients have hip fractures, when patients have multi-morbidity, multi-complex medication issues, we are able to see them and give recommendations as consultants. And so if you have a loved one in the hospital and you're struggling, you should always ask, do you have a geriatric service that does consultation? Maybe they can just have a look and they can see, okay, maybe we can make some recommendations, because you'd be surprised. I mean, we might just recommend to start a little melatonin in the evening to help a person sleep and
Tylenol.
just some Tylenol for pain, and the confusion goes away. I mean, small recommendations, or we may find a medicine that we think is causing the confusion. We get rid of it and the situation is resolved. And then also right in the setting, in an office setting, if your primary care doctor is doing some memory testing and noticing that you have memory problems, if there is a memory clinic nearby, or, we have a memory clinic and we see patients all the time. Our primary care docs refer patients to the memory clinic. We're able to really sit down, do some memory testing, but not only do we do the memory testing, we probably spend an hour just to educate, talk about the diagnosis that the loved one has and the progression of the disease and possibly the type of dementia that the person has. And just being able to have memory care services can prevent a person from getting admitted into a nursing facility or delay the admission for months to years. And it can also delay progression of disease, because we may find ways to delay the progression of disease through pharmacology, either new medications or taking away some medications. Yeah. And I think just, the American Geriatric Society estimated that about 30% of older adults would benefit from seeing a geriatrician. And so I think that's really important to think about. Not everybody needs to see a geriatrician, but 30% is still a lot when we think of the number of geriatricians that are available in the country. Right? We have about 7,000 board-certified geriatricians in the country, and our goal is to make more geriatricians. But by 2029, when the last of the baby boomers turn 65, we are going to be in desperate need of geriatric care. And so I think that we do need to not just see patients individually, but as geriatricians, we are supporting the system. So your primary care doctor may not have access to a geriatrician directly sometimes, but the system may have geriatricians that are supporting your primary care physician too, and you may want to ask about that. Anything else, guys? Dr. Cannon, do you think you could sing for? No, not today. Not with your voice.
I need to rest to be able to give a full performance for the next podcast. Okay. It'll be number 11.
Guest star.
I'll probably, I need my creative thinking to create a new song for you.
You're gonna create a new song? Do you want Mila to create some music for you?
Well, I did get kicked out of my church choir. So if she can auto-tune me, that'd be great too.
She might be able to. I just grabbed her a new guitar, like a big girl guitar finally. So yeah, but
maybe your daughter will be able to sing for us.
She could sing for us, but I love Dr. Cannon's voice. Yeah,
you're the only one.
Dr. Combs, thank you so much. How can people get a hold of you? Where are you working right now?
Oh, so currently I am working at Carolina's healthcare system, Blue Ridge, and I am on several cities in Western North Carolina. So Morganton, Marion, Valdez, Lenoir. But they can reach me at the office or at
Right. I think if you Google Dr. Alison Combs, I think it will come up, right? It's Carolina's healthcare system, Blue Ridge. She's a geriatrician there, and she's seeing patients for consultation in memory clinic, fall clinic, in the hospital. And we are so lucky to have her there, and I'm glad to be working with her. Anyhow, I hope you enjoyed this post. Check us out on social media. Thank you for listening to this episode of the Geri Academy podcast. Learn more at geriacademy.com or follow me on social media for information on future episodes.